So, good afternoon, everybody. I'm co-chairing this session with Thomas Kotulak from Czech Republic. I'm Giovanni Landoni from Milano. The session seems to be very interesting. Each speaker will have overall 20 minutes, that is 15 minutes for the talk, plus 4 or 5 minutes for questions and answers. So the discussion will be at the end of each presentation. You are very welcome to raise your hand and ask friendly questions. So let's start this session with the co-chair presentation, Thomas Kotulak from Prague, Czech Republic. You're very welcome.
Okay, thank you very much, Giovanni. Ladies and gentlemen, дорогие друзья, thank you very much that I can stay here in Astana. It's my 6th or 7th time I'm here, so I'm almost at home here in this beautiful city. And let me talk a little bit about right ventricular failure in cardiac surgery. What are the main causes of right ventricular failure? It's always increased right ventricle preload, increased right ventricle afterload, and decreased contractility of the right ventricle. What are the main causes on ICU? It's volume overload of the right ventricle, which is very common in our intensive care patients. And we have to take care about volume of afterload, especially after initial resuscitation of septic shock and other conditions like that. It could be a pulmonary arterial hypertension, decreased contractility of right ventricle due to right ventricle ischemia, sepsis, right ventricle cardiomyopathy, myocarditis, cardiac surgery, heart transplantation, or cardiopulmonary bypass. And as I mentioned in the beginning, volume overload is one of the most common cases of right ventricle failure. And it could be also, the right ventricle could be also volume overloaded because of tricuspid or pulmonary valve regurgitation. Another reasons on ICU for pulmonary hypertension are already pre-existing pulmonary artery hypertension, increased left atrium pressure, increased afterload of right ventricle due to ischemia, cardiomyopathy, mitral valve regurgitation, and pulmonary artery stenosis. Hypoxia, very common on ICU and very big, one of the most frequent cases of pulmonary artery hypertension due to hypoxic pulmonary vasoconstriction. And it could be on patients with ARDS or with patients with volume overload and resulting edema, lung edema, or in patients with chronic COPD. One of the reasons of pulmonary artery hypertension could be also thromboembolia. It could be also chronic thromboembolic pulmonary hypertension or air embolism. And one of the main cases also could be not proper driven mechanical ventilation with high pressure, high inspiratory pressure, and high volumes. So here you can see a picture how it works, and that there are several reasons of right ventricle ischemia and right ventricle reduced output, leading to left ventricle reduced preload and reduced cardiac output, and then compensatory tachycardia and limited perfusion of right coronary artery and right ventricle ischemia, and so on and so on. Here you can see some physiological consequences of and differences between right ventricle and left ventricle. You can see that there is a difference in the tolerance of changes in preload and afterload between right ventricle and left ventricle. Left ventricle tolerates well sudden rise in afterload and worse sudden rise in preload. In difference with right ventricle, that tolerates better sudden rise in preload. There's a better compliance of right ventricle and worse sudden rise in afterload. Here you can see that for therapy and diagnosis of right ventricle failure, it's extremely important to use a diagnostic transesophageal echocardiography. And one of the methods to identify right ventricle failure could be the eccentricity index due to right ventricle pressure overload with septum deviation and D shape of right ventricle. Another possibility is to calculate right ventricle fraction area change during systolic and diastolic phase of heart revolution. So, what about right ventricle failure in cardiac surgery? One of the reasons could be a pre-existing pulmonary artery hypertension. We know that some of the patient has, and it's an independent predictor of mortality in cardiac surgery. It could be cardiac surgery by itself. It can cause pulmonary artery hypertension or worsening of pre-existing pulmonary artery hypertension, and increase in pulmonary vascular resistance is frequent and reversible after CPB, and it can lead to right ventricle failure. So what are the choices of therapy? What could we do with the patients? There is a choice of drug, and we are looking for a drug who is selective enough not to decrease systemic vascular resistance and mean arterial pressure. There is a question of timing, when to start, if before operation, during surgery, or after surgery, before problems, during problems, after right ventricle failure. And there is a method of drug administration. There is two main methods which you can choose. One is a systemic drug administration, and the second one is inhalation of the drug directly into the lung. And I can say that almost all of these choices of therapy of pulmonary vascular resistance and right ventricle failure are a little bit pricey. So right ventricular increased preload, how we can, what would be a proper therapy? It's due to volume overload mostly. Then we are using diuretics, and we just to solve positive cumulative balance of the patient. Or we can use some continuous venous hemofiltration or hemodialysis just to solve the positive cumulative balance of the patient. And on patients on a left ventricle assist system, we can reprogramming assist system so that we can decrease a little bit preload of right ventricle. If there is a increased afterload for a right ventricle, then we estimate that there is a pulmonary artery hypertension or increased pulmonary vascular resistance. We can use inhaled nitric oxide, we can use phosphodiesterase 3 and 5 inhibitors or prostaglandin. And if there is a decreased contractility, then we have not so good choices, but we can use calcium sensitizer levosimendan or phosphodiesterase 3 and 5 inhibitors like ambrinon and sildenafil. So, regarding inhaled nitric oxide, it's the good news is that it's a selective pulmonary vasodilatation, and there is a very high price and relatively demanding route of administration. Here you can see, and it could not be probably effective in chronic pulmonary hypertension. And there's a risk of pulmonary hypertension after weaning from nitric oxide, so-called rebound hypertension, and there is a risk of creation of carboxyhemoglobin. These are inventors, and these three guys discover nitric oxide as a signaling molecule, and they got a Nobel Prize in 1998. So it's not so long time for me. Here is the mechanism, how it works. I don't think we have enough time to explain, but I just want to show that there is another pathway, intracellular pathway through cyclic GMP and cyclic GMP-dependent protein kinase to decrease binding of calcium to myosin and decrease tonus of smooth muscle. And there is another pathway. This pathway is for nitric oxide, and this is for inhibitor of phosphodiesterase 5 and 3. So there are three different pathways. That means that if you combine these drugs, you can easily increase effect of each drug itself. So what is important on ENO is that in normal physiological situation, if you use NO, it goes only into the ventilated part of lung, so it increase blood flow in ventilated parts of lungs and not increase flow in a non-ventilated, because there is no enough NO. And it doesn't worsening hypoxemia, this mechanism. So where we are using in our department inhaled nitric oxide as a prophylactic use. We are using it in a heart transplantation in patients with known pulmonary artery hypertension. We use ENO for patients with right ventricle failure and reversible pulmonary artery hypertension. And we are using ENO in patients with left ventricle assist device implantation with impaired right ventricle function. And by our meaning, in our department, the optimal dose is 20 ppm, maximum 40 ppm. We don't use 40 because it's too expensive and we don't see any effect. And for the weaning, we are decreasing those to 5 ppm, eventually 1 ppm for 30 minutes. And before weaning from ENO, we start dosing patients with sildenafil, phosphodiesterase 5 inhibitor, just to prevent rebound pulmonary hypertension. So, as I mentioned, there are some problems in clinical use of ENO, like rebound hypertension, methemoglobinemia. You should monitor it. Inhibition of platelet aggregation and increased bleeding of the patient, especially after surgery, and generation of nitrogen dioxide and its toxicity, and generation of peroxynitrite and its toxicity. So in other drug we use in our department is amrinone. Its effect is questionable, but most of my colleagues are strong amrinone believers, and it's not so easy to change the mind of the people, especially if surgeons are believers also. So we are using milrinone, but there is a side effect that there is with a lowering of pulmonary vascular resistance, there is also systemic vascular resistance lowering. I don't think we have enough time, Giovanni. What do you think? 2 more minutes now? Okay. So we'll go directly to sildenafil. We are using sildenafil because it has a minimal effect on system pressure, and there is a significant reduction on pulmonary artery pressure, 60 minutes after administration in patient with mitral valve regurgitation from study of TRACT. So main advantages of sildenafil administration is decrease of pulmonary vascular resistance, increase CO, cardiac output, and decrease pulmonary catheter wedge pressure, in contrast with inhaled NO, where is an increased PCVP, and there is a low or no influence on cardiac output. I'll go straight to the end. And prostacyclines we don't use at this time so much. I think that maybe you use it, but in our department we don't use epoprostenol and iloprost in inhalation form. You can use it in an inhaled form, but it's pricey and it's also demanding for administration. But you can combine these drugs with the other drugs. And there are several non-pharmacological approaches, like correction of acidosis, avoid hypoxemia, improve right coronary artery perfusion, and don't use so much vasopressoric therapy like norepinephrine because it increases pulmonary vascular resistance. Instead of norepinephrine, we are using vasopressin in these situations. Safe mechanical ventilation. You can see that if you use high lung volumes and high inspiration pressures, the capillaries are narrowing and pulmonary vascular resistance increasing. Important is pulmonary artery catheter monitoring and echocardiography monitoring. And levosimendan, I think that there was lectures before. And regarding therapy, in conclusions, right ventricle failure and pulmonary arterial hypertension therapy is complex, and there is a necessity for close monitoring of the patient with TE, pulmonary artery catheter, and ASTRUP to avoid acidosis, to avoid hypoxemia. And we are using in our department combined pharmacotherapy, mostly levosimendan, sildenafil, inhaled NO, sometimes Emrinon. And it's a high-cost therapy, and we are considering early, very early, or concomitant right ventricle assist device implantation when we have a problem with right ventricle failure. Regarding right ventricle failure after left ventricle assist system implantation, it could be early or delayed right ventricle failure. Right ventricle function determinants are the same, preload, contractility, and afterload. So these are the places where you can do something. And right ventricle function could be impaired before, during, and after right ventricle assist system implantation. And important could be maybe pericardial preservation techniques and avoid excessive inodilatary therapy like Emrinon, levosimendan to decrease need of the vasopressor therapy. And this is interesting article you have to read about right ventricle failure after on a patient with left ventricle assist system. That's probably all. Thank you for your attention.
Nice, very academic and useful presentation. I've learned a few key points. Is there any question from the audience? I have a couple. If they don't have, I have a couple. The first one is, which is the incidence from your experience? Is it 10% or 100% of right ventricular failure after cardiac surgery? Well, how many patients?
I think after normal cardiac surgery, it could be less than 10%. Serious.
The serious one.
Serious. I don't mean temporary and in patients with left ventricle assist system implantation, it could be maybe around 40–50%. But okay. Not all of these cases are necessary for right ventricle assist device implantation. But
sure.
Do you have same?
I don't have numbers. Yeah, I guess that more or less the numbers are this one. Probably we go very high if we include the moderate levels of.
It's
right.
one of our most serious problem after left ventricular assist device implantation. And now we learn that if you are waiting for organ complication such as liver failure, acute kidney injury, it's too late for implantation.
Yeah. For LVAD, we assume that all of them potentially have right ventricular function, and we give to all of them nitric oxide, inotropic vasoconstrictors, including levosimendan. We also give intra-aortic balloon pump to, to all these patients as a cocktail for
So the same
all of them. There is a question from the audience.
You don't say how you use
dobutamine. Dobutamine we use mostly. I like dobutamine actually. I like it more than amrinone and levosimendan and other drugs. But dobutamine we are using as a drug of choice, as an elementary drug of choice in a normal bypass and other things. Sometimes we don't use dobutamine in these patients because it increased tachycardia due to amrinone and levosimendan administration. And it's questionable with levosimendan at this time, especially after these two last year articles about levosimendan.
Okay. Thank you very much for your presentation. 20 minutes overall, so you were perfect. And now we have the next presentation. Okay, so does it mean that the Saudi Arabian colleague is not in the room? If there is a speaker from Saudi Arabia, please raise your hand. No. So that is okay. The slides were okay. The slides were okay. So we now go to India, Sterling Hospital, Vadodara. And the title of the presentation is Combined Cardiac Surgery and Oncosurgery. Is it feasible when necessary? This is a very original topic presented by Abhishek. Thank you very much for being here.
Thank you, sir. Good afternoon, everyone. Myself, Dr. Abhishek Raichura. I'm working as a consultant cardiac anesthesia in Sterling Hospital. This is our hospital. It's a tertiary care hospital situated in our region. It's total bed capacity of 300. We have some cardiac surgery volumes around 350 major surgeries per annum and oncosurgery volumes about 450 major surgeries per annum. I will be talking about cardiac diseases and malignancy. And in cardiac diseases, especially ischemic heart disease, are increasing in incidence all over the world. The reasons and risk factors may be changes in lifestyle and food, smoking, increasing incidence of smoking, obesity, increasing incidence of diabetes and hypertension, genetics and hereditary factor, and sometimes it is better diagnostic and increasing life expectancy also. Valvular heart disease like rheumatic heart disease are very prevalent in developing countries like India. In developed countries, senile aortic stenosis and mitral stenosis and myxomatous mitral valve regurgitation are common. Similarly, malignancy shares some risk factors with the cardiac diseases like changing food habits and lifestyle, smoking, obesity, exposure to pollutants and others, and similarly increasing life expectancy and better diagnostic capabilities. So it is going to be an increasingly common scenario to find combined cardiac diseases and malignancy, and the possible scenarios, if not all, then the possible scenarios will be patient presenting with malignancy for surgery, it requires surgery for malignancy, and in preoperative examination to detect it to have significant cardiac disease like ischemic heart disease or valvular heart disease which requires immediate care, or vice versa. Patient with previous radio or chemotherapy for malignancy as a neoadjuvant therapy presenting for cardiac surgery now, and patient who has previously undergone valve surgery or CEBG or PTCA presenting for oncosurgery now, because it is a cardiac patient now. So I want to share details of 3 patients of combined cardiac surgery and oncosurgery done at our institute, followed by some discussion about this combined scenario. The first patient was a 56 years female who was hypertensive, diabetic, and having truncal obesity. She presented to the oncosurgery department with a invasive ductal carcinoma of breast, and it was confirmed on FNSC. It was T2N1M0 stage 2A on staging, and so posted for modified radical mastectomy by the oncosurgery department. During preoperative history, patient gave history of unstable angina to the anesthetist, and their resting ECG was suggestive of STT changes. So a CEG was advised by the cardiologist, and it showed triple vessel disease, which was critical. And 2D echo was suggestive of good wide ventricular function. This was the angiography. The RC was getting filled retrogradely. This was the postoperative images and intraoperative image of the patient. Oncosurgery in first stage in this patient would have increased the perioperative risk because of critical triple vessel disease, while CEBG in first stage would have delayed the MRM for at least 3 to 4 weeks till the patient recovers from the CEBG and sternal wound is healed. So combined op-pump CEBG and modified radical mastectomy was planned by the combined decision of oncosurgery and cardiac surgery teams. General endotracheal anesthesia was given in a routine manner with invasive arterial pressure monitoring and CVP monitoring, just like in a op-pump CEBG. First op-pump CEBG was done with SVG graphs to LAD, OM, and RCA. Heparin effect was reversed and protamine was given, and ACT was normalized. Hemostasis and closure of sternal wounds was done. It was confirmed that there is no excessive bleeding after CEBG, and after confirming the stability, hemodynamic stability of the patient, left modified radical mastectomy was started. It was done with axillary dissection, and total surgical duration was 330 minutes, 2 units of PCVS transfused. Care was taken to avoid excessive hypothermia and to correct any hypothermia, aggressively correct hypovolemia, hematocrit, and acid-base disturbances in perioperative phase. In postoperative stay, patient was ventilated overnight, and stay was uneventful. As a rule, in our setup, all these 3 patients were ventilated overnight to correct acid-base disturbances and to correct any kind of hypovolemia or hematocrit disturbances. Postoperative radiotherapy and chemotherapy was started as per routine schedule as advised by oncosurgery, and which was not delayed because of combined surgery. No sternal wound issue or MRA wound healing issue was found. Second patient was a 48 years female who complained of abdominal pain for 1 month and dyspnea on exertion on routine activities for 6 months. She was diagnosed as ovarian malignancy with severe mitral valve stenosis and mitral valve regurgitation with moderate TR with severe PH. Coronary angiography was done preoperatively, it was normal. Here also doing mitral valve replacement and tricuspid valve repair in first stage, the cardiac surgery would have delayed the oncosurgery by at least 4 weeks with the possibility of malignancy spread. Also, warfarin had to be started after mechanical valve replacement because she was a young patient, and it has to be stopped for oncosurgery, and bleeding into the ovarian cyst during that intervening phase was also a possibility according to oncosurgery. So oncosurgery first would have increased perioperative risks because due to cardiac condition of severe MS. So combined open heart surgery and oncosurgery was planned. Here is the intraoperative phase pictures of this patient. Here, general endotracheal anesthesia was given in a routine manner with invasive arterial blood pressure CVP monitoring. Intraoperative TE was used as it is used in all cases of valvular heart disease, in addition to routine ASA monitors. Mitral valve replacement with St. Jude mechanical valve and tricuspid annuloplasty was done on CPB first. After that, heparin effect was reversed and ACT was normalized, and care was taken similarly to correct hypothermia, hypovolemia, acidosis, and anemia, any anemia due to CPB. After that, laparotomy with total abdominal hysterectomy, bilateral salpingo-oophorectomy with thrombectomy, and bilateral pelvic lymph node dissection was done. Thorough hemostasis and closure was done. Postoperative stay was uneventful except a delirium on second postoperative day, which was for what no reason was found, and it was self-limiting. Post-operative chemotherapy was started after 3 weeks. It was not delayed. In third patient was 72 years male, hypertensive for 10 years. He was diagnosed as carcinoma of left side of tongue with left side lymph node spread, T2N0. In preoperative workup also, the patient showed severe left ventricular systolic dysfunction with LV of 30%, and ECG showed STT changes. Coronary angiography was done. It was suggestive of critical triple vessel disease. Here also, the critical cardiac condition necessitated that CEBG should be done first. But to avoid delay in oncosurgery and radiotherapy post-operative phase, if required, combined cardiac surgery and oncosurgery was planned. General anesthesia with nasotracheal intubation was done. Invasive monitoring was used. Open CEBG was done with IBP support with graft to LAD, obtuse marginal and RCA, which was followed by local excision of carcinoma tongue and modified radical neck dissection. Post-operatively, patient was kept in cardiac intensive care unit for 4 days. Ventilatory and IBP support were weaned off on the second day. Rest of the post-operative stay was uneventful. Radiotherapy was started after 3 weeks. Here is the intraoperative pictures of this patient. So, combined cardiac surgery and oncosurgery, when it may be necessary. It may be necessary when the patient presenting with malignancy, which requires urgent surgery for malignancy, which can otherwise progress, and patient detected to have simultaneous critical coronary artery disease or ischemic heart disease and valvular heart disease, which requires urgent attention also, and otherwise it can increase the perioperative risk for the oncosurgery. So it becomes a very tricky situation in these patients. Doing cardiac surgery first prior to oncosurgery would delay oncosurgery and subsequent radiotherapy chemotherapy in such patients. Similarly, doing cardiac surgery in second stage after oncosurgery can potentially delay postoperative chemotherapy, radiotherapy that may be required for oncosurgery due to obvious concern of the sternal healing and wound healing. So the advantages of doing cardiac surgery and oncosurgery in a combined manner in a single stage are no delay in oncosurgery, less chances of malignancy spread. Postoperative chemotherapy, radiotherapy is not delayed. It can be started on routine time. No issue of stopping antiplatelet therapy or warfarin or any kind of bridging therapy kind of maneuver post-cardiac surgery for oncosurgery. No increased perioperative risk for oncosurgery because of critical cardiac condition like valvular heart disease or ischemic heart disease. However, there are some challenges or issues which needs to be considered when a team is contemplating to do combined cardiac surgery and oncosurgery. Just like increased duration of surgery is always there, but it can be acceptable when the combined cardiac surgery and oncosurgery teams are expert in their work. Sequel of surgery has to be decided preoperatively by the consultation between the two teams. Doing cardiac surgery first and reversing the anticoagulation is a better way because that will help reduce in the bleeding in the oncosurgery, in the postoperative phase. While doing oncosurgery first can cause surgical site bleeding due to heparin or CPB effect in the cardiac surgery that is done after the oncosurgery. There may be problems because of old age of the patient and frailty of the patient. Increased use of blood component and increased fluid in electrolyte shift and hypothermia is also a possibility. Another things which needs to be considered specifically in thoracic surgeries or lung surgeries in oncosurgery is the sternotomy is preferred approach by most of the teams when they are doing pneumonectomy or lobectomy. They do prefer to do it by sternotomy and it is done before cardiac surgery and before CPB. It avoids CPB-related coagulopathy and possibility of tumor spread by CPB. However, left lower lobe of lung, when to be approached, it is approached on CPB. It provides better exposure and less hemodynamic changes. There are chances of mediastinal contamination when the GI tract is going to be opened in oncosurgery. So that thing needs to be kept in mind when the team is contemplating combined surgery. There are consideration of changing the patient position if it is required. For example, thoracotomy, lateral position after sternotomy closure in cardiac surgery can cause some problems because of tunnel movement and there may be increased bleeding and drainage. Similarly, sternal delayed healing because of postoperative chemotherapy and radiotherapy is also a concern. It needs to be taken care and needs to be consulted with the patient and the team preoperative also only. There are challenges related to prior radiotherapy and chemotherapy taken by patient. I will come to it next. So, if the patient has taken preoperative radiotherapy as a neoadjuvant therapy to decrease the, for oncosurgery purposes, there may be some issues. if the radiation dose is more than 25 to 30 gray, it is more likely to cause damage. And the early effects may be acute pericarditis, pericardial exudates, and fibrinogen pericarditis, and adhesions in pericardium. So in such patients, doing cardiac surgery is a little bit challenging, and there may be adhesions, so it needs to be considered by the team pre-operative only. Late effects like myocardial fibrosis and dysfunctions are possibility. Similarly, if the patient has received pre-operative chemotherapy, there may be some issues like cardiotoxicity, which may be type 1 cardiotoxicity or type 2 cardiotoxicity. Type 1 cardiotoxicity is more dangerous, and it causes almost irreversible structural damage if detected late. It causes cardiac dysfunction like left ventricular ejection fraction reduction and CCF with myocarditis. It is seen with doxorubicin, epirubicin, and even with high-dose cyclophosphamide. And in this phase, type of cardiotoxicity, early detection by left ventricular strain imaging and aggressive treatment by early detection is the key of avoiding excessive damage. Similarly, some drugs like Herceptin, trastuzumab, and bevacizumab can cause type 2 cardiotoxicity, which is largely reversible, and there are no or minimal structural damage. So when a patient has undergone preoperative chemotherapy, it needs to be considered when the postoperative surgery is to be considered in such patients, and left ventricular ejection fraction has to be assessed by strain measurements and by accurate measurement of left ventricular ejection fraction, and patient needs to be counseled that postoperative also there may be reduction in left ventricular ejection fraction because of this cardiotoxicity of the chemotherapy. Other changes like arrhythmias, ECG changes may be a possibility. Similarly, altered liver function tests, renal function tests, nausea, vomiting are a possibility. So whenever we are considering combined cardiac surgery and oncosurgery, PTCA instead for coronary artery disease instead of CEBG may be option. It is a lucrative option, but it is possible when there is a double vessel disease or a single vessel disease and lesions are stentable. It involves less morbidity than CEBG, and there are faster recovery. However, double antiplatelet therapy is necessary for 1 year after drug-eluting stent, and it would cause delay in the oncosurgery. And interrupting dual antiplatelet therapy before oncosurgery in a very short period of time can cause increased risk of stent thrombosis. So, however, it may be beneficial in cases of post-radiotherapy patients when there are chances of mediastinal fibrosis. While CEBG does not need dual antiplatelet therapy post-operatively, and oncosurgery can be done after 3 to 4 weeks of recovery or even concomitantly with oncosurgery. So, the conclusion is question whether to do or not to do combined cardiac surgery and oncosurgery. Well, it's a multidisciplinary approach. Each patient needs to be assessed by the team of cardiac surgery and oncosurgery preoperatively. Patient-specific decisions has to be taken by weighing risk and benefits, and patient needs to be consulted, and patient needs to be explained about all possible options, and best option should be advised by the team. So, combined cardiac surgery and oncosurgery is feasible, provided the clinician treating the patients are thorough with cardio-oncology and act as a part of multidisciplinary team. Thank you. These are the references.
Thank you very much. Very original presentation. Any question from the audience? I have many, but I will ask you just a couple of them. How original is it? I mean, how many other publications did you find in the medical literature combine cardiac and non-cardiac surgery?
There are many publications, sir, and there are many reference articles also. Which deals with cardio-oncology, that is the separate branch now emerging, which deals with such kind of patients who are having combined cardiac disease and medical disease. It is a separate branch now emerging in the last few decades. And it deals with the issues of perioperative chemotherapy, radiotherapy, issues of myocardial dysfunction, radiotherapy issues, preoperative, postoperative, and the assessment which needs to be done in this patient preoperatively and in perioperative postoperative phase. Similarly, there were many case reports about combined cardiac surgery and oncosurgery involving various surgeries like GI surgery, GI oncosurgeries, and thoracic oncosurgeries like pneumonectomy, lobectomies, and other oral cancer surgeries and gynecological cancer surgeries. There are many literature reports. So it's not uncommon. As I said, it's going to be increasingly common scenario. And with the increasing incidence of both malignancy and cardiac surgery, we are going to find, in the increasing life expectancy of the patients, we are going to find more and more older patients who are going to more likely to have malignancy, and they're also more likely to have ischemic heart disease. So I think the teams all over the world are going to witnessing all these patients in an increasingly common manner, I think.
Next, please.
That's I understood his question. He is very much right. I understood his question.
Yeah, just to summarize, he was saying that probably doing less invasive cardiac procedures like stenting or balloons for the aortic valve, instead of the aortic valve replacement, is probably safer for the patient. That is most probably
yes, sir,
true.
You are very much right that whenever patient is patient for malignancy is detected as critical cardiac condition, it needs to be assessed by the cardiac team, by cardiologist, a cardiac anesthetist, and the cardiac surgeon, and the patient should be given the least risky option, as you said. And if the cardiologist is ready to put bare metal stent, and patient is also ready to take the bare metal stent, and ready to understand that whatever risk of restenosis are there with the bare metal stent, and ready to understand that, then the bare metal stent are a better option. Even the balloon angioplasty is also an option in such patients. If the lesions are stentable, as I said in last slide, PTCA is a very lucrative option in some of the patients, but patients should understand that putting a bare metal stent or doing balloon angioplasty itself is increased risk. And nowadays, with the cardiologists going for drug-eluting stent routinely, they are very much jittery about putting bare metal stent and doing balloon angioplasties. And in our part of world, whenever, and in our part of world, whatever the valvular heart disease we find are very much calcific mitral valves, and our patient, as I described, it was having severe MS with MR and tricuspid regurgitation with severe PH. So she was not a very good candidate for balloon mitral valvulotomy. And most of our patients are very much advanced in stage. They have very calcified and very bad valves, and they are many times not a very good candidate for balloon mitral valvulotomy. So it's a limit. But if the patient is suitable candidate.
We have another comment or question.
I'm Dr. Gaurav from the same institute, and I'm the operating cardiac surgeon with him. He is my chief of anesthesia. What I have understood in a little bit of 3 patients is you cannot condemn a 42 or 48-year-old woman having triple vessel disease to bare metal stents, who is in stage 2 disease of CA breast and has a good option for a life expectancy of at least 10 to 15 years. If that is what we happened, we also have a learning curve. We started doing FEMPOPs and CABGs together. We all have done it. So why not? If we can meticulously plan, see, we have been thinking an MRM with an axillary dissection is limited to your subcutaneous tissue and your fat. So if your wound healing is fine, and your surgical time and your experience is good, and your teams are ready to play in tandem, that is never going to create a problem. Again, combined valvular procedures, as he rightly showed, an MS with an Elkins of 13, 14, that is what we get in our country, which is still a developing country. We have a very high incidence of mitral stenosis. Severe PAH, what do you do? You just cannot leave the patient condemned to one of the two diseases. You cannot do that. So you have to keep on reinventing it, and that is how the world has to move. We have to keep on looking for a better future for our patients. And together we can, believe me. Thank you.
Okay, thank you.
Hi. Can I make a statement?
Another?
I'm Dr. Nambiar. I'm a surgeon from
okay.
India again. Now, the issue is in European countries, I lived in the States for very long. The issue in European countries is you have a national health service. Unfortunately, in India, everyone pays out of pocket. So the more procedures you have, the more expensive it is. So I think Dr. Gaurav has done an excellent job. Thank you.
That's an important point of view, I think. I have a question if there's any evidence or any literature regarding post-oncosurgery metastasis in combination with cardiopulmonary bypass in a one-time operation.
There are some concerns which, like that CPB can cause tumor spread. That is one concern. And that is why, as I tell, in in lung surgeries, they try to, there is a theoretical concern. That's not proven that, but that CPB causes tumor spread. And that is why they try to do it. The teams try to do the oncosurgery in lobectomy, pneumonectomy for lung cancer prior to CPB. That is one theoretical concern.
Okay, thank you. Another questions from auditorium? Okay, one more question.
Yeah, I think the best way to go, if we now know, if we see that it is feasible, without the publication bias, the best way to go would be to introduce a randomized study. And only in that way we can get evidence that this would be what the value would be of the outcome of this therapy. And not just by not declaring feasibility as the introduction of a larger introduction in itself.
Sure, thank you.
This is 3 patients hypothesis generating, definitely original, and thank you very much for your contribution.
So I would like to invite next speaker, and I can't read it. It's Dr. Zellmaker Rost, and autotransfusion has an important effect on drug dosing in congenital cardiac surgery.
Yes,
Welcome.
thank you. Yes, good afternoon, ladies and gentlemen. I would like to talk to you about autotransfusion and its important effects on drug dosing in congenital cardiac surgery. As you know, donor blood is often used in almost all congenital cardiac procedures, mainly due to the use of the cardiopulmonary bypass. However, donor blood also increases the risk for postoperative morbidity and mainly postoperative infections. Therefore, the use of a cell-saver system is necessary to reduce the need for donor blood. However, there are no studies on the influence of autotransfusion on drug concentrations. And a clinically relevant drug concentration could be returned to the patient in the intensive care. If you look at the timeline, the cell-saver system is used during surgery. However, the cell-saver is processed and washed by the end of surgery, and the cell-saver product, so the autotransfused blood, is usually returned to the patient after surgery in the first few hours on the pediatric intensive care unit. And the aim of our study was to measure drug concentrations, thank you, in blood that was saved from the operation site, and also to measure drug concentrations in the autotransfused blood to determine if a clinically relevant drug dose is returned to the patient. Thank you. We've conducted this research at the Department of Cardiothoracic Surgery of a tertiary university hospital, the Erasmus MC, and we've sampled at 4 different stages of the cell-saver procedure. I'll come back to these stages later. And we've measured the concentrations of sufentanil, propofol, midazolam, and cefazolin, which are routinely used drugs during congenital cardiac surgery in our institution. Here you can see the cell saver. The first sample we took was from the reservoir, where the blood comes in after it's being suctioned out of the operation site. Then the blood passes through the processing bowl on the low left. Then the second sample was taken after processing. Then the blood passes through a lipophilic filter. The third sample was taken after the lipophilic filter, so this is the end product of the cell saver, called here the autotransfused blood. We've also taken one sample from the waste fluids, so the material that is washed out during the cell saver procedure. Due to time considerations, I will not go into the waste fluid samples. Our results, we have taken samples, so 4 samples per cell saver run from 19 cell saver runs in total. We did this in 18 patients. 1 patient had a prolonged procedure and needed 2 cell saver runs. The age of the patients varied from 2 months till almost 12 years. And the most performed surgical procedure was a correction of ASD type 2, with some other procedures as well. The total blood loss during surgery was a wide range, but median was 90 milliliters. The cell saver volume processed and the cell saver product returns are a larger amount of blood because the residual volume that is left after the procedure in the cardiopulmonary bypass is transferred to the cell saver system, and that's also processed and together with the other transfused blood returned to the patient. The washing fluids that was used during the processing of the cell saver volume was approximately, well, a mean of 780, but it was quite a widespread. Most patients had 1 cycle of washing. However, there were some patients with 2 and 1 with 3 cycles. The amount of the washing fluid used was mainly dependent on the volume of the cell saver blood being processed rather than on the washing cycles. Our results first for sufentanil. All patients received sufentanil, which is a highly lipophilic drug, highly protein bound, and it is also a small molecule. We recovered about 32% of sufentanil concentration in the autotransfused blood. I will just walk you through the box plot. The blue bar is the concentration of the sufentanil that we recovered from the reservoir. The reservoir concentrations for sufentanil, like for all drugs we have measured, is comparable to concomitant patient samples. So this is a clinically relevant drug dose. The red bar is after processing by the cell saver, but before the lipophilic filter. So you can see that it's a little bit compressed. And the green bar is the other transfused blood. So this is after passing through the lipophilic filter. And these are our results for propofol. Only 6 of the patients received propofol. Also a highly lipophilic, highly protein-bound drug with small molecule size. We recovered about 17% of propofol concentration in the autotransfused blood. These are our results for midazolam. We have also measured the active metabolites of midazolam, namely the 1-hydroxymidazolam and midazolam glucuronide. These, especially the 1-hydroxymidazolam, is as biologically active as midazolam is, so for the clinical purposes we thought it would be very useful to know. 1-hydroxymidazolam is also a lipophilic drug, but a little bit less than midazolam with a log P of 2.7. We recovered about 5% of midazolam in the autotransfused blood. The results shown here are from 1-hydroxymidazolam. We recovered about 11.5% of that. We only recovered about 5% of midazolam glucuronide. Also, all patients received cefazolin, which is the only hydrophilic drug that we have measured. Less protein bound, but also a small molecule. And we recovered about 4% in the autotransfused blood. So to conclude, there are drugs recovered in autotransfused blood. Depending on the drug, it can run up from 5 to 30%. Therefore, also a return of clinically relevant drug concentration could lead to unwanted reaction postoperatively on the pediatric ICU. However, this would not go for all patients. Probably the patients with the biggest risk of an unwanted drug reaction would be a very small patient, a neonate perhaps, with major surgery, because you would have a large volume of cell saver product that is returned to the patient, mostly in a bolus dose, not a continuous IV infusion as you would normally give. And also probably because of the use of the cardiopulmonary bypass, the patient might have a decreased clearance of drugs from the body, so he would be at risk for accumulation of drugs and thus unwanted drug reactions. Also, the influence of a cell saver system should be considered in pharmacological research during and after cardiac surgery, because it might be an additional compartment for loss and recovery of drugs. However, we mainly recovered lipophilic drugs, but it also ranged from 5 to 30%. We would have expected to have some influence of sequestration in the cell saver system, like we also noticed to happen by ECMO or in the cardiopulmonary bypass, but that did not really seem to happen. Also, there was no influence of the lipophilic filter, so the widespread of 5 to 30% we cannot really explain this at this moment, also because the drug characteristics seem to be fairly similar. And with the washing of the normal saline fluid that we use, we cleared out most of the hydrophilic drug, but we only measured one hydrophilic drug. So maybe that conclusion is a little bit well, early at this stage. We do believe that for future research this is a very good starting point, this pilot study, and with larger sample size we might be able to give more definite answers of the influence on the cell saver system on drug concentrations. So I thank you for your attention.
So thank you for very, very original work. I have 2 questions, but do we have another questions in auditorium now? No? So I can start. First question is, and I think it's very important, did you measure also antibiotics? Because we have in our protocol, if there is a big, huge blood losses during cardiac surgery, but I work in adults cardiac surgery. So we have in our protocol redosing of antibiotics because of loss of antibiotics. So it would be probably important issue to measure it. But I have a question. What is the practical issue? Because if you are not using cell saver, then you lose 100%. Okay, and here you are losing less. So you are redosing, increasing dose, or because you have to make some recommendation what to do if you use a cell saver and whether you don't use cell saver. And I'm not pediatric anesthesiologist, so I don't understand it. Thank you.
At this moment, it's probably too early for a definite recommendation. To come back to your other question, for redosing and the way to administer the drugs, we have done this study as a sub-study really of a larger study we're doing with 150 patients on the influence of the cardiopulmonary bypass on pharmacokinetics and pharmacodynamics of drugs. So we've included 150 patients in that. We've also, as a part of that, done the in vitro study of all the cell saver systems that we've used. And probably if we can combine that, and then we also have the administration and redosing of drugs, but also loss of volume, but also additional volume, that would probably give a good recommendation in drug dosing. And the cell saver would be one of the things that might influence a drug dose or drug concentration, whether the cell saver is used or not, how big your patient is, how many cell saver products you have left, and when will you give it back. So it's sort of a bigger picture here. Okay.
Just a last question. You say about drug reaction. I can imagine there might be some hypotension if you reinfuse high dose of lipophilic opioids. Is there any other clinically relevant reaction that you anticipate, that you foresee?
Well, it could be in patients that are extubated, so no longer on mechanical ventilation. We sometimes do that 1 or 2 hours after surgery. And then if you would give back a relatively high dose of opioids, strong opioids, then you might have a respiratory depression. So that would be our main focus, I think. Yes. Okay, thank you.
Thank you. Any other questions? No. So it's my privilege to introduce my co-chair and Giovanni Landoni from San Raffaele Hospital in Milan.
Thank you very much. Good afternoon, everybody. My first time in Astana. These are Italian guys who are cycling for the Astana team worldwide. This is my hospital in Milano. Looks quite exotic, and you probably know Milano because of fashion, or maybe you know it because of arts and museum, La Scala. But if you are in the field of cardiac anesthesia and cardiac surgery, you probably know it. You probably know my hospital because of Professor Alfieri of the edge-to-edge mitral repair technique working there. I have no conflict of interest. I have to disclose. I have several disclosures. One is including Neoton that I will address briefly during my presentation. And another disclosure is that I have an obsession to study mortality reduction in several clinical settings, including the perioperative period. I recently put all my ideas in this article. So these are the ideas that are just personal ideas, because if you go and look into guidelines, what reduces mortality in the perioperative period, or what does reduce mortality in the perioperative period of cardiac surgery, you don't find one guideline. There is not such a paper, not such a guideline. There are beautiful guidelines on every specific topic, how to reduce bleeding, how to manage mitral valve patients, but there is nothing that focuses on survival. So here I will spend just a few seconds. These are my ideas. Maybe your ideas are different from mine. This is what we do in our hospital. We use a lot of non-invasive ventilation, both in the ICU and outside the ICU. We have a medical emergency team done by anesthesiologists and intensive care specialists that reach the patients within few seconds after the call, and it's very democratic. Everybody in the hospital can call the anesthesiologist. Even, when I say everybody, is everybody. We do a lot of research. Remember that doing research in your hospital raises the quality of the care you're giving to your patients. Of course, being operated in a big hospital is fundamental for the survival of the patients. Of course, here I'm not talking about having a good surgeon. That is, of course, the best predictive factor for your patient. And then you can have an ECMO team, you can have a sepsis team, an acute pain service team. So all these things are not strictly evidence-based medicine, but I think all of them, or at least most of them, are rational to improve survival in our centers. And then there is hyper-specialization, debriefing, standardization, checklist. All these things are already widespread around the world. We attempted to do something original, and you find a few weeks ago we published this manuscript where we put together the randomized evidence of mortality reduction in the perioperative period of cardiac surgery. So this is a mix between a consensus process, and we have added a bit of democracy because we asked to 1,000 of colleagues to agree or not with the topics that we identified. So we attempted to identify all the randomized evidence that lead to mortality reduction in cardiac surgery, and then we asked 1,000 colleagues from 78 countries to agree or not with these topics. And as I told you, this was published a few weeks ago. I have a problem with this one. Okay, so this is the list. I will briefly focus on the right side. So what is reducing mortality in cardiac surgery? We ask all the 1,000 colleagues if they agreed or not with these topics and with these sentences. And so let's start. Let's focus on cardiac surgery, and the first topic is glycemic control. So every cardiac surgical ICU has some kind of glycemic control. There is randomized evidence that this can be associated with a mortality reduction in the perioperative period. The suggestion is not to be too strict. So please use your own protocol for insulin administration in post-cardiac surgical patients, but take care of hypoglycemia. And you see that approximately 90% of our colleagues worldwide agree that a continuous infusion of insulin after cardiac surgery probably improve survival. Intra-aortic balloon pump, or the high volume centers are using it in complicated patients. The preoperative use of intra-aortic balloon pump seems, in high-risk patients, seems to be associated with an improved survival. Of course, you are aware of a large recent New England Journal of Medicine paper suggesting that intra-aortic balloon pump is not reducing mortality in patients with acute myocardial infarction and shock. So probably the best in cardiac surgery is to use it either in the very high-risk patients or in those that immediately after cardiopulmonary bypass have some kind of complication. And just for the technician, I'm just saying that this one is not working anymore. So it's not following my rhythm. If you have another one, it's better to find it. Because I push and the green light is on, but the slides are not moving. So we need another one.
Здесь какая-то проблема с этим remote control.
It's not taking not keeping my pace. So the next topic was leukodepletion. In medical literature, you find two randomized trials suggesting that leukodepletion is life-saving in cardiac surgical patients. and colleagues agree that this is a potentially life-saving topic. If I remember well, the next topic was a selective digestive decontamination. This is something that is very peculiar because most of the colleagues think that this is working, but few colleagues are applying it. So if you give a combination of antibiotic that will kill only germs in the gastrointestinal tract, there is the possibility that you save lives due to a reduction in the translocation of germs from the gut to the blood if the patient has a complicated course. So here there are countries that are applying this technique routinely, and there are countries that are not. And who is not doing it, that is the majority, is afraid of increasing or creating multi-drug resistance. But this is I think is a very hot topic for the future. And in my presentation, there was only one drug that increased mortality in cardiac surgery according to randomized evidence. You can guess what it is, and it is a proteinin. So a proteinin is the only drug or technique or strategy that has randomized evidence of a mortality increase, thank you very much, of mortality increase in the perioperative period. So this was leukocyte depletion, and you see that 90% of the colleagues agree that this is potentially life-saving. I forgot to mention levosimendan, nice new inotropic agents. Our group was the first one in 2010 to suggest that this could be life-saving, and many centers are increasingly using it. People is agreeing that it is potentially life-saving. You know that 3 large trials published in the New England Journal of Medicine this year are telling us that this effect, at least the effect on survival, is not so important and pronounced when you perform a high-quality research. This is the selective decontamination. We have already talked about this. Another topic that is improving survival, potentially improving survival, is volatile agents. There is initial randomized evidence that these drugs are life-saving due to a pharmacological effect. So not an anesthetic property, but a pharmacological organ cardiac protection effect. The meta-analytics results are impressive, and we are conducting a large trial, 10,000 patients, to definitely show if this effect is there or not. And this is funny, remote ischemic preconditioning. Funny because it's a strange technique to give brief period of ischemia to the arm to see if there is an effect on organ protection or not. The results are promising. I've seen there are several presentations on this topic in this Congress, and we are studying it in non-cardiac surgery. So I move to the second part of my presentation that will be very short. We'll deal with neoton because we did a recent meta-analysis showing a potentially mortality reduction when using this energetic drug in the cardiac patient. So this is a manuscript published a few months ago, and this is an in-press paper that you will find in PubMed in October. So these papers are telling us that when you take all the published evidence on phosphocreatine and you put it all together, you see a mortality reduction, and this applies when you include more than 3,000 of patients. So more than 3,000 of patients have been studied so far. When you put all this evidence together, you see an impressive mortality reduction from 10 to 3% when using phosphocreatine. These patients are cardiac surgery patients, congestive heart failure, and coronary artery disease patients. All these outcomes go in the, let's say, right direction, and most of the evidence comes from the cardiac surgical setting. And you see mortality decrease, ejection fraction increase, cardiac biomarkers really reduces, and then there is a reduction in major arrhythmias and inotropes. On average, the dose was 4 grams. In most of the trials, this was added to the cardioplegia solution. This drug started as a cardioplegic agent or supplement, but is now used also intravenously, since it is a good transporter of energy, intracellular energy transported. The trials included in the meta-analysis were quite international, and the article was article of the month for EACTA, and so this is why we decided to perform a further meta-analysis focuses on cardiac surgery only and on randomized evidence only, 26 trials overall, and the results are definitely similar. Reduction in the use of inotropic agents, reduction in major arrhythmias, and increase in the number of patients with spontaneous recovery of rhythm and circulation after cardiopulmonary bypass, and this is the future. 200 patients randomized trial that is currently running here in Asia, in Novosibirsk, Siberia, in a big center, and the name of the protocol is PRIZE, and the outcomes are still explorative. So this is my email address. If you send me an email today, I will send you the PowerPoint of the presentation and other papers that I have briefly showed. The take-home message is, yes, there are drugs, techniques, or strategies that probably reduce mortality in our setting, and it is worth knowing them and studying them. Thank you very much for your attention.
Thank you, Giovanni, for a very nice presentation. It's like recreating something, or there is a resurrection of very old ideas, because I remember in the 90s we were using neoton in each disaster in our OR. So I'm going to use it next week. Okay. I have a question. What do you think, what is the power of ideas of 1,000 cardiac anesthesiologists without any other questions, you know? Just you feel you like it. So for me, it's if it's in it's a little bit like in our country that because of democracy we have very stupid president, you know, and maybe there could be some criticism on these ideas if it's useful, if so many people think that something is good, if it's you know, scientific or evidence-based, or just, yeah. This is not joking, just question, you know.
No, it's a very important question. So this democracy-based medicine approach is definitely not liked by experts. So they like to be the one telling us which is the truth, and in most occasions, probably this is the best approach to follow. I mean, having people that are very competent, very expert, who study the literature on our behalf. But I think in few occasions, this can help the scientific community at least a bit. So strictly under the methodological point of view, having 1,000 people from 70 countries is not a representative, I mean, it's not very representative or good under the methodological point of view, but I think under the practical point of view, you avoid the conflict of interest, you avoid the national strange habits. I mean, this is just a general picture of what people think around the world. I think it can just help a little bit more, and adding just a little bit to the experts.
Maybe it could be helpful for some more meta-analysis and new studies. If it's you know, in fashion for so many people, maybe we have to watch it. If it's the same like you did with Nelson, probably.
Yeah, you can say it can be hypothesis generating. Yeah.
Any other questions? No? I think it's so provocative, so there should be some questions. No? Okay, thank you, Giovanni.
We move to the last presentation of this exciting session. Especially, this is exciting because I've never seen in a cardiac surgical congress so many people attending an anesthesia and intensive care session. So thank you very much for being here. The next speaker is again from India, Harsh Seth from Mumbai. He will talk about elevated red cell distribution wide. So thank you very much for being here.
Good afternoon. Cardiac surgery with cardiopulmonary bypass provokes a systemic inflammatory response. This is due to contact activation of blood by artificial surfaces of the extracorporeal circuit. In extreme form, it leads to systemic inflammatory response syndrome, multi-organ dysfunction, and death. It's going back again. Okay. Yeah. Red cell distribution width is a quantitative measure of anisocytosis. Red cell distribution width is recently described by a novel biomarker predictive of adverse outcomes in multiple cardiovascular disease. Aims and objectives. We aim to determine the relationship between RDW and SIRS through our study. Material and methods. A retrospective analysis of 1250 patients who underwent cardiac surgery with extracorporeal circulation from August 2012 to August 2016 in our institution was done. They were divided into two groups, SIRS and control, each having 26 patients. The inclusion criteria in the SIRS group, we identified 26 patients with SIRS who presented with 2 or more of the following features: temperature more than 38 degrees Celsius or less than 36 degrees Celsius, heart rate more than 90 beats per minute, respiratory rate more than 20 breaths per minute, partial arterial carbon dioxide pressure of less than 32 mm of Hg, white blood cell count of more than 12,000 or less than 4,000 per microliter. Patient who had 2 or more were fitting into the criteria. Exclusion criteria: mechanical ventilation more than 48 hours before surgery, preoperative infection, death during the surgical intervention or in the first 48 hours after surgery, proved postoperative infection within the first 5 days, or a record with incomplete data. In the control group, 26 consecutive patients with similar demographic parameters who underwent cardiac surgery with extracorporeal circulation in the similar time frame were taken. The following parameters were noted: demographic, hematologic and biochemical, perioperative data, postoperative data, arterial blood gases. Baseline RDW values were measured with use of Sysmex XT2000i automated hematology analyzer. The normal reference range for RDW in our laboratory is 11.6% to 14.8%. The operative procedure: the same anesthesiology and surgical team operated on all the patients. Standard median sternotomy incision was done. Aortic cannulation, single or bicaval cannulation. Membrane oxygenator was the same in all patients. Single cross clamp, antegrade root or ostial cold blood cardioplegia was given. Mild to moderate systemic hypothermia, 28 to 32 degrees Celsius. ACT of 450 to 600 seconds when the cardiopulmonary bypass was initiated. In patients with coronary artery bypass grafting, at least one arterial graft and several venous grafts were used. Proximal anastomosis of the venous grafts was done on beating heart using a side biting clamp. Valve replacements were performed using pledgeted sutures in horizontal mattress fashion. And antibiotic prophylaxis at the time of induction with cefazolin sodium 30 mg per kg at induction and repeated every 4 hours during surgery. Results. The demographic profile of our patients was similar. RDW was significantly higher in the SIRS versus the control group, which amounted to a statistically significant amount. Of the total 1250 patients, 33 of them had a high preoperative RDW. Out of the 26 patients who developed SIRS, 22 of them had high preoperative RDW values. This is the baseline clinical and demographic parameter. We assessed the age, gender, diabetes, hypercholesterolemia, ejection fraction, smoker, hypertension, COPD, and Euroscore. All of them were demographically similar and none of them amounted to statistically important significance. There was a significant mortality in the SIRS group as compared to the control, 26.92% as compared to 7%, which amounted to a statistically significant value. Multiple logistic regression analysis revealed a positive association with high RDW and development of SIRS after extracorporeal circulation. The odds ratio for levels exceeding 13.5% confidence limits had a statistically important value. The operative data in both the groups. Both combined surgery, valve, and CABG was done in 8 and 6, respectively, in SIRS and control group. Isolated valve was done in 8 and 10 in the two groups. Isolated CABGs was done 10 in each. The important is the operation time had a significant increase in the SIRS group, but the CPB time and the clamp time was pretty much similar in both the groups. The need for inotropic support was higher in the SIRS group, while blood transfusion was similar in both the groups. The use of intra-aortic balloon pump was more in the SIRS but did not amount to any statistical significance. The laboratory parameters were more or less similar, but the statistically significant values were RDW, which showed a significantly high range in the SIRS group as compared to the control, and so was the fasting blood glucose. This is a representation of high RDW in SIRS patient as compared to the control patients. Discussion. This study shows us the importance of preoperative RDW as a predictive marker for development of SIRS after extracorporeal circulation. Since RDW is a routine parameter available in complete blood count, it can be easily used. This syndrome occurs in about 0.5 to 1.7% in patients who've undergone ECC in literature. It is associated with multi-organ failure, which has a mortality of 40 to 60% and even higher in some series. In our study, the incidence of SIRS was 2.08% of patients with a mortality of 76.92%. The patients who expired in the SIRS group ultimately had multi-organ failure. The reason for high RDW may be under pulmonary or cardiovascular stress, such as hypoxia or low cardiac output. There is increased cytokine level which attenuate the activity of erythropoietin. This results in production of ineffective red blood cells, leading to elevated RDW. In our study, patients with RDW value over 13.5% increased incidence of SIRS. This relation became even stronger when the value was more than 15%. A receiver-operator curve analysis suggested the optimum cutoff level for RDW for SIRS patients was 12.9% with a sensitivity of 93% and a specificity of 76%. This is a proposed hypothesis of SIRS post-extracorporeal circulation. It happens after extracorporeal circulation. There's activation of inflammatory mediators, cytokines, interleukins, platelets, adhesion molecules, which acts on the hematological system, leading to dysregulated erythropoiesis, leukocyte activation, increased capillary leakage, impaired perfusion, which leads to SIRS and multi-organ failure. Limitations. Our study was retrospective. The sample size of the study group is small. We did not take into account any congenital heart conditions. This was a single center study. There are confounding factors, known and unknown. Definition of SIRS, which is used, is very broad, and we did not use any quantitative marker to quantify these patients with SIRS. But in conclusion, the finding to be noted is that there is some positive association between elevated RDW and development of SIRS after extracorporeal circulation. And since it's a routine hematological parameter and has no additional cost, it is a good idea to keep a watch on this value so as to have better management of these patients. We can apply this information such that in such patients we can avoid CPB altogether. We can use leukodepletion filters, use of hemofiltration in appropriate patients, and take early aggressive measures in such patients. Prospective randomized control would even further validate these findings. These are my references, and thank you for your kind attention.
Thank you for an interesting presentation. I have to think about some question, and are there any questions from auditorium? So you think that increased red blood cell need after CPB is one of the trigger of systemic inflammatory response, or it could be vice versa, that complications during operation and maybe longer CPB and other things, maybe more bleeding, so that you need more blood, packed red blood cells. It could be also triggering because we know that if you need some red blood cells after operation, it dramatically increase risk of wound infection and other things in cardiac surgery. So maybe your idea on it?
That's definitely true, that these factors do influence the incidence of SIRS in patients. In our study, the operation time was definitely a confounding factor in these patients. Mm-hmm. But the cardiopulmonary bypass time and the cross-clamp time was similar in both the groups. So yes, definitely the operation time does take into consideration increased incidence of SIRS, and as you said, blood transfusion, all this definitely makes a mark. Since it was similar in our study, we couldn't comment on that, but yes, definitely increased red blood cell transfusion will lead to increased SIRS.
And maybe it was in your presentation, what was the transfusion trigger, and was the transfusion trigger same for all of the patients?
It was pretty much similar, like generally 2 bags for the SIRS group, and in the control group it was 2 plus minus 0.8.
Okay, thank you.
Thank you.
Any other questions?
I just have a comment and suggestion. There are a couple of large trials on cortisone, on steroids, that were recently completed. My suggestion is to write to the authors of the manuscripts and ask them to check this data in their patients, if that is available. Okay. Because I think there might be some interesting finding. Yeah, some interesting finding. Thank you very much for your presentation, and thank you very much to everybody for being here this afternoon.
Thank you for your valuable advice.